Hello, dear friends. Very warm welcome to today's session, which is Recall MCQ session from the FMGE December 2021 exam. And I'm going to discuss the ophthalmology MCQs, which were there in this year exam here in December session. So we'll be taking it as a recall MCQs because they are based upon the recall by the students. So we have tried to collect as much MCQs as possible. But I would like to tell you in the beginning itself, as you know, that since they are based upon the memory recall, so there can be some deviation, rather expected deviation from the original questions which came in the exam. As far as the statements are concerned, the wording is concerned, or the choices are concerned. But the usefulness of this kind of session is that because that helps us to identify the high yield topics there. Okay, and we can discuss these questions and we can know that what kind of topics, what kind of important high yield topics are there for the upcoming exams also, because very soon we are going to have the NEET PG exam also. So these topics, they stay important even for that. So once again, welcoming you all to today's session. I'll be discussing ophthalmology FMG December 2021 recall MCQs. Anuradha, Dhawan here. So before, without wasting any more time, I would say let's start with the questions itself, right? So the first question which I'm going to discuss is a clinical case scenario. Most of the students, they have told that there was no image in this case scenario. It was just the scenario which was described. So the question came something like this, that a 67-year-old patient presents with sudden painless loss of vision in the emergency, and his fundus examination shows pale retina with red spot in the center. What is the most likely diagnosis? So as I have been telling in my previous sessions in which we practice a lot of MCQs or the clinical case scenario, that always try to look for the keywords in the case scenario statement. So this is the way to approach these kind of questions. So here there were two key I would say two key statements which were given in the question. One was the sudden painless loss of vision. Okay, now this is very important. Sudden, so something which has happened, that is why the patient came to the emergency. Painless loss of vision usually is associated with the retina diseases. And then the findings in the fundus, they are very, very classical. They are the keywords which will help you clinch the diagnosis. So what were the fundus examination findings described? Pale retina. So pale retina indicates ischemic retina, that the retina to which blood supply is compromised, and with a red spot in the center. So this red spot, as you all know, is known as cherry red spot, but because it looks like the color of the cherry. So whole of the retina, the rest of the retina is pale and ischemic, but the center of the macula, that is fovea, retains some amount of blood supply because it is getting it from the choroidal vessels also. So that is why it appears red in color. Okay, so these are the key points in this clinical case scenario: sudden painless loss of vision and the fundus findings of pale retina with red spot in the center. Now we have something in our mind, and let's see what were the choices given to us. Choice A was marked as CRAO, B CRVO, C cystic edema, and D macular edema. Unfortunately, examiner gave as an abbreviation CRAO, CRVO, which I would suggest is not very good thing to do, because they should have written full terminology. But we know CRAO stands for central retinal artery occlusion. CRAO stands for central retinal artery occlusion, and CRVO stands for central retinal vein occlusion. So this is what is like meant by CRAO and CRVO. The third choice is cystic edema. So cystic edema is again mostly seen in the macular area. The D choice was given in macular edema. Now, if we discuss these choices, cystic edema and macular edema will never cause sudden loss of vision. Okay, sudden loss is not seen in these two conditions. Usually, it will be gradual progressive loss as the edema is happening in the central area. Okay? A and B, in both these cases, sudden and painless loss of vision can occur. But what is the difference? Difference is in the fundus finding. So if we recall from our previous discussions, we know that pale ischemic retina, as you are seeing over here, this whole of the retina is pale because of the ischemia. The central part of the retina is showing you cherry red spot. This is the finding in the cases of CRAO. This is the classical fundus picture of central retinal artery occlusion. Okay, so that helps us to make the diagnosis. Why it is not CRVO or central retinal vein occlusion? Because in central retinal vein occlusion, fundus is spluttered with the hemorrhages. There are multiple retinal hemorrhages, what we call as tomato splash appearance. So the fundus appearance of CRVO is totally different. Tomato splash appearance in which you see lot of retinal hemorrhages. So in that way, we can clearly differentiate from the fundus findings, whether it is a CRVO or CRAO, though both of them, they can present with sudden painless decrease in vision. Okay? So I hope this question is clinical cases clear to all of us now. This is a very common case scenario. In the past exam, lot of times question based upon CRVO had come. This time they gave a question on CRAO. So we should be very clear in our mind whether we are dealing with vein occlusion or we are dealing with artery occlusion. So right answer to this question statement was your choice A here, that is CRAO, because painless loss of vision with pale retina with red spot in the center is seen in the cases of CRAO, right? So moving on to the next question, which was there in this session exam. Let's go to the question statement. Again, this was a clinical case-based scenario. A young patient with history of contact lens presents with foreign body sensation, red eye, and watery discharge. Most probable diagnosis is. So here, again, let's try to look for the key words in the case statement. So a young person, then history of contact lens use. So this is an important clue over here. Patient is having history of contact lens use. Then what are the symptoms which are described? Foreign body sensation, red eye, watery discharge. So foreign body sensation is that when a person feels that there is something inside the eye, which is like a foreign body. So these kind of things, they can happen in multiple, rather in all of the choices which are given here. A person, what are the choices? Corneal aberration, VKC, that is vernal keratoconjunctivitis, giant papillary conjunctivitis, and dry eye. Now, here in all these conditions, a person can have foreign body sensation because the eye surface is not normal. But what are the other symptoms associated which are given here? Red eye with watery discharge. Now, in dry eye, usually we will not see red eye with watery discharge. The patient will have rather dryness of the eye. Then VKC, if we talk about vernal keratoconjunctivitis, then here they are talking about a young patient with contact lens use. We know VKC is more common in young children. It's a mostly allergic conjunctivitis which is seen in young children. and it has more tendency to occur during the summer season. And history of contact lens use is not necessary for vernal keratoconjunctivitis because it will be very unlikely that a child is wearing contact lenses. So the use of contact lenses is important to note in this question. Then corneal aberration. Corneal aberration means that a person has rubbed the eye. That is why there is epithelial injury to cornea. Nothing of the sort has been mentioned in this clinical case scenario. So we can rule out corneal aberration also. So we have to see that which choice is matching the most with the clinical case which has been given in the exam. So here, giant papillary conjunctivitis is your most appropriate answer because giant papillary conjunctivitis is associated with formation of papillae, which are big in size, which are known as you see these lesions here, these are your papillae, the large papillae over here. When their size is big, they are called as giant papillae. So you can see giant papillae here. So these giant papillae, they can occur as a allergic reaction to contact lenses also. So giant papillae can be seen in VKC also. They occur in reaction to contact lenses, especially your soft contact lenses also. Okay? So since this case is describing us a patient who is a contact lens user and having foreign body sensation, watery discharge. So here it's again a type of allergic reaction, but it is in response to contact lens. And this type of allergic reaction in response to contact lenses is known as giant papillary conjunctivitis. Giant papillary conjunctivitis. So here the right answer to this particular case scenario will be, as I have marked here, giant papillary conjunctivitis. Okay? So there was some, I was discussing with some students, there was a confusion that whether the case was about a young child who is having these kind of features, but in that case, contact lens use history will not be there, or the symptoms, they will be more in the summer season. But if the case statement is showing you that there is a history of contact lens use with foreign body sensation, red eye, and watery discharge, then the right answer to mark here becomes your giant papillary conjunctivitis. So if it is young boy, young child with symptoms more in summer, then it is VKC or vernal keratoconjunctivitis, as we all know. Okay? So the right choice will depend upon what was the exact wording in the exam. But if this is the case scenario, then your answer is giant papillary conjunctivitis. Okay? So let's move on to the next question. So this was an image-based question in which an instrument is shown to you as shown here. So this instrument is used in, the question asks you to identify the instrument, and then you have to find out that this instrument is used for what purpose. The choices were DCR, that is dacryocysto-rhinostomy, probing and irrigation, evisceration, enucleation. So let's identify the instrument first of all. So as you see here, this is a punch. Okay, so this is your bone punch. The bone punch, the purpose of the bone punch will be to punch and remove a piece of bone. Okay? Now let's see what are the choices which are given to us, and we can find out that this instrument is used for what purpose. So let's go from below. Enucleation. The enucleation surgery, as friends you know, is removal of the eyeball, removal of whole of the eyeball along with a part of the optic nerve is known as enucleation, small stump of the optic nerve. Okay? So that is your enucleation. Now in enucleation, bone punch has no role. Bone punch has no role. So this is ruled out. Then what is evisceration? Evisceration means you are removing the inner contents of the eyeball. So certain conditions, for example, panophthalmitis, we just leave out the external shell, the scleral shell, and we scoop out the inner contents of the eyeball. That is your surgery of evisceration. So again, in evisceration, bone punch, that is cutting of the bone, has no role. So this is ruled out. Choice B, probing and irrigation. Probing and irrigation is a procedure which is done in the cases of nasolacrimal duct obstruction. This is usually done in an age group of less than 3 to 4 years. That when a child has a congenital nasolacrimal duct obstruction, so around less than 4 years of the age, we do probing and irrigation to kind of see that where the blockade is, or whether we can open the blockade by doing probing of the lacrimal drainage tract or NLD or not. So again, no role of bone punch there. So bone punch is not there used. Then DCR, yes. DCR is a procedure again which is done for nasolacrimal duct obstruction. Either if it is congenital after the age of 4 years, or in adults when they have chronic dacryocystitis, which is causing infection again and again. So there we do procedure of DCR. Now in procedure of DCR, we are making a new opening of nasolacrimal duct. For that purpose, we have to remove a small part of the bone, and that is where the bone punch is used. So right answer to this question is this is a bone punch which is used for DCR. So let me just explain it to you a bit more here with the help of this image. Now this is your NLD. This you can see is your nasolacrimal duct. So normally anatomically we know the nasolacrimal duct, it opens into the inferior meatus. It opens into the inferior meatus of the nasal cavity. Now when there is obstruction of the nasolacrimal duct, that is why there is infection of the lacrimal sac. So this is what is happening in nasolacrimal duct obstruction. So in DCR, that is dacryocystorhinostomy, we are making a new opening in the middle meatus. We are making a new opening in the middle meatus. For this reason, we have to remove part of the bone here. We have to remove part of the bone here so that you can make a new opening in the middle meatus. So that is where this bone punch is used. That is where this bone punch is used. So this is used in DCR, right? So let me just have you revise what are the other instruments which are used for the procedures which were described in the choices. Now here, this is your lacrimal probes. These are your lacrimal probes which come by the name of Bowman lacrimal probes. They are the one which are used for probing and irrigation. They are known as Bowman's lacrimal probes. So you put different sizes and you see whether you can open the passage or not. Okay? And this instrument here is your evisceration scoop. Evisceration scoop, which is used in the surgery of evisceration because you want to remove the contents of the eyeball. And this lower one is your enucleation spoon. Enucleation spoon, which has a guide for the optic nerve. You engage the optic nerve in this area and you remove the eyeball with a small stump of the optic nerve. Okay? So these are the instruments which are for the procedures described otherwise in other choices there. Okay? So hope we are very clear. So because the instrument based questions, they are also expected. They can show you a Clausian clamp. They can show you instruments used in the cataract surgeries. And here we have discussed enucleation spoon, evisceration scoop, Bowman lacrimal probe. So all these, they can be helpful for the upcoming exams also. So here the right answer to this question is now clear. This is a bone punch and this is used for DCR, right? So we can move on to the next question now. The next question was, visual acuity of a person improves on looking through the pinhole. This indicates. Now, this again is a good question. In one of the NEET PG exam, there was an image of the pinhole and there was a question based upon to identify that. So here there is visual acuity of a person improves on looking through the pinhole. What does this indicate? The choices were retinal disease, macular disease, refractive error, astigmatism. So before answering this question, let me take you through how the pinhole looks like. So this is your pinhole. This is your pinhole. So why it is called pinhole? Because it's like an occluder that it will occlude the rest of the eye so that the person can see only through this small opening, only through this small central opening, which is about 1 millimeter in size. So this central 1 millimeter opening is there. When we place the pinhole or a person looks through this pinhole, then the light passes only through this central opening. So only that beam of light enters the eye and helps in focusing the image on the retina. Now, what is the use? The main use of the pinhole is it helps us to differentiate that whether a person is having decreased vision due to refractive error or due to some other abnormality, which can be your macular diseases, the diseases of the central retina, or it can be a central cataract, or it can be a corneal opacity. So we can understand that if central axis of the eye is clear, that is, there is no macular disease, there is no central cataract, there is no central corneal opacity, then the vision will improve with pinhole if a person has refractive error. So if a person has refractive error and there is no organic cause of decreased vision, then the vision will improve because now the light rays, they will be passing through the central opening and focusing directly on the central retina. But reverse, if the central retina is diseased, that is, if there is disease of the macula, then the visual acuity will decrease. So if vision improves on pinhole, that indicates refractive error. That indicates refractive error. If it decreases, that indicates macular disease, right? So here what they asked us was that visual acuity of a person improves on looking through the pinhole. So this indicates that there is a refractive error. In macular diseases, it will decrease on looking through the pinhole. Retinal disease will depend upon, because if it is extensive disease, it will not improve. Improvement occurs only when there is refractive error, and that too usually up to 3 diopter, because otherwise it will not improve with the pinhole. Right? So pinhole improves the vision in cases of refractive error. Okay, coming to the next question. So there was this, just like the last time or most of the recent trends, most of the questions, they were based upon the clinical aspect of ophthalmology. As you must have seen, a lot of questions, they had images also. So that underlines the importance of going through the images, which I have been highlighting always, going through the importance of the clinical case scenarios. So it's important for every upcoming exam there. So what was this case scenario about? So let's read out the statement. A farmer presented with pain, photophobia, and watering from the eye for last 36 hours. On examination, an ulcer is seen as shown. Identify the lesion marked. So again, a very nicely put question, I would say, because here they have given you a case scenario based upon which you have to identify what disease we are discussing, and then you have to identify a specific lesion over here. So what were the keywords here? Let's go through the keywords. Farmer. So farmer means he is prone to trauma with vegetative matter. Then he is having pain, photophobia, watering. Pain, photophobia, watering usually occurs in 3 conditions: when there is corneal ulcer, it can occur in acute angle closure glaucoma, or it can occur in the cases of uveitis. Okay? But if it's a farmer, then the chances of having a trauma and resultant corneal ulcer is much more. Then already they are showing on the image a corneal ulcer there. So they have now told you that it is a corneal ulcer, and you can see on the image it's a corneal ulcer. Now identify the lesion mark. So here we can identify from the history as well as from the lesion that what ulcer it is. So if farmer gets an ulcer, most likely it is going to be fungal corneal ulcer. It is going to be fungal corneal ulcer. And if you see the image which they had described and the lesion they are asking, they have marked the arrow at, there is a main ulcer. You can see there is a main ulcer here. And then there are many small, what we call as satellite lesions, So let's go through the choices. The choices also which they gave were satellite lesion, hypopion, dendritic ulcer, ring infiltrate. So let me go through, take you through the image once more. History is telling us that it is a fungal ulcer because it is a farmer. Then the lesion also which they have marked. What are the features of fungal ulcer if we revise? Raised infiltrate, feathery margins means indistinct margin, satellite lesions. So what they are showing over here is the satellite lesions means small lesions away from the main ulcer. This is the main ulcer, but then main ulcer, as also you can see, it doesn't have a definite margin there, and there are multiple satellite lesions. So let's go through the choices once more. Satellite lesions, we are marking it right. Yes. Hypopion is a collection of pus. So if there is a collection of pus in the interior chamber like this, that will be hypopion. But they have not shown a hypopion here. So this is not the case. Dendritic ulcer is seen in the cases of viral keratitis, and it has a shape of a dendrite. So this is not shown here. Ring infiltrate or ring ulcer will be in the shape of ring. It will not be in the shape of the satellite lesions, and most commonly it is seen in the cases of acanthamoeba. So this is again not the lesion which they have marked with arrow. So the lesion which they have marked with arrow is your satellite lesion. So this question I really appreciate as a very good question, because that is telling you how to identify which type of ulcer it is, and that is also telling you how to identify specific characteristic of that type of ulcer, because satellite lesion is specific of fungal corneal ulcer. It is specific of fungal corneal ulcer. So we are clear about the answer here, satellite lesion. Then moving on to the next question. The next question, again, whether it was given only as a statement or it had an associated image. There are like two kind of opinions about that. But even if there was no image and only statement is given, you can identify the choice here. What was the statement or what was the question? Identify the given condition with inward rolling of lid margin. So here, inward rolling of lid margin. So this is very important. In which condition the inward rolling of lid margin occurs? The choices given to us were ectropion, entropion, dystichiasis, tracheasis. Okay. Now let me just take you through what all the other choices are. So if you look here in this image, what do we see? We see that lashes, the eyelashes, they are rubbing the surface of the eye. Eyelashes are rubbing the surface of the eye because they are misdirected. They are directed towards the eyeball. But if you notice the lid margin is normal. There is no in-rolling of the lid margin. So this condition is known as tracheasis. The misdirected lashes which rub the eyeball, this condition is known as tracheasis. Then there can be an extra row of the lashes. So you notice here, that there is a normal row of lashes and then there is an extra row of lashes here. This condition is known as dystichiosis. This condition is known as dystichiosis. Okay. And what else? If we see here, what are we seeing here? Again, we notice that there are the eyelashes which are rubbing the eye surface, but even the lid margin is enrolled. The whole of the lid margin is enrolled. So this is known as entropion. This is known as entropion, enrolling of the lid margin. And reverse of this is ectropion, but you notice here, outward rolling of the lid margin. So this is ectropion. Now, all these are important terminologies which we must remember, and important image-based question also. So they can come as either. So we are clear what is entropion, ectropion. Difference between trichiasis and entropion is trichiasis only lashes they go inside, misdirected. In entropion, whole of the lid margin is inward rolled. So this was what was asked in the question here, that identify the condition with inward rolling of lid margin. So I hope it's now clear to us. This can be only entropion. Inward rolling of lid margin, entropion. So whether image is there or just the statement is there, we can mark the answer as entropion. Moving on to the next question there. A child presents with defect in vision, but on examination, fundus is normal. What could be the diagnosis? Now here again, there could be chance that we are missing few words here, but we will try to answer this question as to the best possible answer here, because this question appears a little incomplete in the statement. So if you find corrections in the questions or the choices, then please do leave your comments there. So that will be helpful to further refine the recall sessions. Okay. So let's see what they have told. A child has vision defect, but on examination fundus is normal. So what are the choices? Astigmatism, amblyopia, myopia, hypermetropia. Now here the best answer, because what do they mean to say is that vision is defective, but there is no organic cause of loss of vision. What they are trying to tell us is that there is no organic cause of vision defect. Organic cause means that some pathology in the eye structures which could define the defect in vision. So when there is decreased vision in the absence of an organic cause, that is known as amblyopia. That is known as amblyopia. And in those cases, the fundus will be normal in examination. The fundus will be normal in examination. Amblyopia, if we describe amblyopia, is in common words, it's also called as lazy eye. It's also called as lazy eye. It is suppression of the vision in the absence of any organic cause. Absence of any organic cause. So that is what we call as amblyopia. There can be various types of amblyopia depending upon the underlying reason. That is strabismic amblyopia, when there is squint in one eye. Anisometropic amblyopia, when there is difference in the refractive error of the two eyes. There was a question based upon that also. Sensory deprivation amblyopia, for example, congenital cataract. But in all these cases, the fundus is normal. So still the patient is having defect. Another important question related to amblyopia can be the treatment of amblyopia. The treatment of the amblyopia, most effective treatment of the amblyopia is what is known as occlusion therapy. Occlusion therapy, what do we mean by occlusion therapy? we patch the good eye of the child so that he or she uses more of the lazy eye and vision can be stimulated in that. So that is known as occlusion therapy. You are trying to stimulate the lazy eye by patching the good eye. So for this particular question, there can be, as I told you, maybe incomplete statement, but defective vision with fundus normal, the most appropriate choice is your amblyopia, right? So let's move ahead. So another clinical case-based scenario with an image, a child aged 1.5 years comes with leukocoria as shown in the image. The most probable diagnosis is retinoblastoma, rhabdomyosarcoma, congenital cataract, congenital glaucoma. So a child in an age group of 1.5 years with leukocoria. So leukocoria means, as you see over here, a white papillary reflex. A white papillary reflex is known as leukocoria. Leukocoria, there can be multiple causes. Most common cause of leukocoria is congenital cataract, but most dangerous cause is retinoblastoma. And as you know, if you remember, the most common presentation of retinoblastoma is leukocoria, that is white papillary reflex. So when there is a child who is 1.5 years old presenting with leukocoria, then a possibility of retinoblastoma should be kept in mind. Now, whether there was an additional statement of the flexner ventricular rosette in this question is not known, but even based upon the information which is written here and going by the choices, we can mark the right answer. The choices were retinoblastoma, rhabdomyosarcoma, congenital cataract, congenital glaucoma. So congenital glaucoma, as you know, is buphthalmos, in which there will be big sized eyeball, there will be hazy cornea, blue sclera. So this is not a case of that. Congenital cataract can present with white reflex, but there you will not be able to see the retina. So here, if you notice carefully, you can see in the reflex, it is a reflex which is coming from the retina, not from the lens. So congenital cataract is also ruled out. Then rhabdomyosarcoma. Rhabdomyosarcoma is the most common intraorbital tumor. It is a tumor of the orbit in children, primary tumor of the orbit. So this is not the case. So right answer to this question is retinoblastoma. If there is an additional point given of the flexner ventricular rosettes, as you see here, then the diagnosis is complete because flexner ventricular rosettes are specific of retinoblastoma. Flexner ventricular rosettes are specific of, there can be other types of the rosette, Homer right, pseudo rosettes, but these rosettes are specific of retinoblastoma. So right answer to this question is your choice A, that is retinoblastoma. Again, a very important topic for any exam as far as ophthalmology is concerned. Then let's move on to the next question. The next question, after an accident from metal works, that is some metal factory, a mechanic got injured from metallic foreign body. The investigation of the choice is, the choices given to us were MRI, CT scan, B scan, nuclear radiology. So what do we suspect here when they are talking about a case scenario in which there is accident at the metal work? So metal work, usually small chips of the metal, they are flying. In the cases of when there is work based upon the metal, it can be hammer and chisel kind of work or something like that. And there is a high chance that the person has intraocular foreign body, that metal went inside the eye. So when you want to diagnose that whether there is an intraocular foreign body and where it is located, that is localization. So what will be the choice? So here, if we see the choices, Choice A, MRI. So MRI will be contraindicated. MRI will be contraindicated. So you can imagine the reason, because if there is a metallic foreign body, it can be iron foreign body, metallic or iron foreign body, then it can displace if you take a person for MRI, which is using magnetic field. So MRI is absolutely contraindicated when you are suspecting a metallic or iron intraocular foreign body. CT scan is the investigation of choice because that will help us in accurate localization, and it is safe as far as the metallic part is concerned. B scan. B scan means ultrasound. You can do ultrasound, but sometimes small foreign bodies, they can be missed and the localization may not be that good as CT scan. So investigation of the choice remains CT scan. Similarly, nuclear radiology has no role for intraocular foreign body. So here the right answer is CT scan. Okay. So besides this part, as far as intraocular foreign body is concerned, we must remember usually metallic foreign bodies are more common, and in metallic foreign bodies, if they are retained inside the eye, supposedly iron foreign body is retained inside the eye, what can happen? It can cause retinal toxicity. It can cause retinal toxicity, and the condition is known as ocular sidrosis, or what is known as sidrosis bulbi. It is known as sidrosis bulbi. If the iron foreign body remains retained inside the eye, you do not remove it, it can cause retinal toxicity. The second common one is your copper. If the copper foreign body remains inside, that condition is known as chalcosis, and it produces symptoms in the eye or signs in the eye just like Wilson's disease. Similar kind of the picture, sunflower cataract, KF ring, it can occur in the cases of if chalcosis occurs. This occurs when you leave the foreign body inside the eye. So it is very important that we diagnose it, and if it is to be removed, we'll remove it. So investigation of choice for a metallic foreign body is CT scan. CT scan. Okay. Let's move ahead. A person with paralysis of all extraocular muscles, what is the most probable site of lesion? So in the brain, what will be the most probable site of lesion if a person now has paralysis of all extraocular muscles? We know which are the extraocular muscles, the recti and the oblique muscles. So let us see what are the choices given: upper medulla, lower medulla, pons, midbrain. So paralysis of all the muscles, extraocular muscles, we know what are the nerve supplies. All the muscles are supplied by third nerve except lateral rectus, which is supplied by the sixth nerve, and superior oblique, which is supplied by the fourth nerve. Okay. Now, out of these, third nerve and fourth nerve, they arise from midbrain. Sixth nerve arises from pons. So this question has a little bit of ambiguity in it. Maybe one of the choices was brainstem, because if brainstem is the choice, then that becomes the most appropriate answer. But going by the choices which we can recall, upper medulla, lower medulla, not in the picture. Pons, because sixth nerve is there, but here they are describing paralysis of all extraocular muscles. So midbrain becomes the most appropriate choice here. Although if the choice of brain stem was there, that will cover the question more completely. But out of the given recalled choices, if it was midbrain, you will mark midbrain. Right? Okay, so let's go ahead to the next question. There is a difference in the visual acuity between the two eyes. What is the cause of decreased vision? Again, a very good question. Difference in the visual acuity. First of all, we have to understand what that condition is known as. So difference in the visual acuity is known as anisometropia. Okay. So when there is anisometropia, what is the cause of the decreased vision? Now let's go through the choices. Anisometropia, anisometropic amblyopia, refractive error, anisokenia. Again, here now there can be difference in the choices, but everybody was sure that the choice of anisometropic amblyopia was there, which is actually the right answer. Now, let's discuss it a bit here. So, when there is difference in the visual acuity, when there is difference in the visual, in the refractive error of the two eyes, that is known as anisometropia. Difference in refractive error of two eyes is known as anisometropia. And anisometropia itself will not cause decreased vision. It is the amblyopia due to anisometropia which will cause, because one eye which is having less refractive error will be a better seeing eye, and the one which is having more refractive error will become the lazy eye. So it is the amblyopia which is the cause of the decreased vision. If there is a term by the name of anisokenia, anisokenia is difference in the size of image formed by the two eyes. Difference in size of image formed by the two eyes. Now, this also occurs when there is significant anisometropia. That one eye which is having different refractive error, the size of image is different. The other eye, the size of image is different. So that is known as anisokenia. So here the question is asking us that what is the cause of decreased vision? The cause of decreased vision is anisometropic amblyopia, which is lazy eye due to difference in the refractive error. Difference in the refractive error of the two eyes. That is anisometropic amblyopia. Okay. Okay, then a very straightforward question was asked. Biconcave lens is used in. Biconcave lens is used in treatment of the choices myopia, hypermetropia, astigmatism, presbyopia. So all these are the different states of the refractive errors here. So in which condition we use biconcave lens? So if we remember, concave lens means minus lens. Concave lens means minus lens, and I had given a very easy hint to remember: M for minus lens, M for myopia. So biconcave lens is used in the treatment of myopia. How? Because what is myopia? You remember, in myopia, the image is formed in front of the retina. In front of the retina. Why? Because converging power of the eye is more. The rays are converging in front of retina. So you will use a minus lens, or what we call as concave lens, so that the rays, they focus on the retina. So you are using a minus lens or a concave lens so that the rays, they focus on the retina. And the reverse is required for hypermetropia. In hypermetropia, the rays are converging behind the eyeball. So here we will use a convex lens, or what is known as plus lens, so that converging power of the eye is enhanced and the rays, they focus on the retina. So for hypermetropia, plus lens or the convex lens. For myopia, minus lens or concave. They have to be, of course, biconvex and biconcave. So that will be the term which has been used here. So the answer to this question is biconcave lens is used in myopia. For hypermetropia, we use convex lens. For astigmatism, we use cylindrical or toric lens. For a presbyopia, again we use convex lens. So biconcave for myopia. So this was a simple, straightforward question there. Then another straightforward question based upon the community ophthalmology, the most common cause of blindness in children, whether it was mentioned for India or it may be there in the statement. The choices were cataract, glaucoma, trachoma, vitamin A deficiency. So among the different causes, the most common cause of blindness in children is vitamin A deficiency. There was probably a choice of refractive error also. So there can be different choices here. Maybe there was a choice of refractive error too. Refractive error will be the most common cause of ocular morbidity, that is decreased vision. But when we talk about blindness, then we will mark vitamin A deficiency as the most common cause. And just to tell you a bit more about vitamin A deficiency, we know the bitted spots, they are seen in vitamin A deficiency, and it is the stage of what is known as keratomalacia, which causes the blindness. Keratomalacia means that there is corneal ulcer, as you can see, because of the vitamin A deficiency, there is sort of melting away of the cornea. And when the cornea is getting melted away, that leads to blindness. So it is the keratomalacia or due to vitamin A deficiency, which is the most common cause. And treatment, of course, you know, is the vitamin A supplementation, which is again important question to remember. So most common cause here, the answer will be marked as vitamin A deficiency. Moving on to the next question. So next question again was a case scenario. So as you can see, the ophtha questions, lot of case scenarios were there. Patient had a fight following which he presents with non-reactive pupil and painful ocular movements. The most probable diagnosis is. So here the keywords are that there is a trauma, history of trauma, a fight. Then there is a non-reactive pupil, painful ocular movements. So the choices given were cataract, optic neuritis, glaucoma, pupil sphincter tear. So again, for this particular question, I find it little incomplete. Maybe there was some difference in the terminology here. Two choices we can mark out easily here. Cataract will not be sudden and it will not cause non-reactive pupil. So that is ruled out. Glaucoma, again, there can be glaucoma after trauma, but that will not be like sudden, that immediately the patient is having this kind of problem. Now, trauma can lead to tear of pupillary sphincter. Pupillary sphincter is the muscle, that is the sphincter pupillae, which makes the pupil constrict. So when there is a trauma, the sphincter can be injured and there can be non-reactive pupil. Okay? Then optic neuritis is a condition in which we know there are painful ocular movements. But in optic neuritis, the patient will not have non-reactive pupil. Optic neuritis, the patient has RAPD or Marcus gun pupil. Marcus gun pupil. So this question is a little doubtful. If we talk about the painful ocular movements, you tend to think about that, okay, this is optic neuropathy after trauma, but they have used the word optic neuritis. If you talk about non-reactive pupil after trauma, then chances of pupillary sphincter tear are more, because if there is sphincter pupillae is damaged, so then the pupil will not react, pupil cannot constrict. So then this choice becomes more appropriate. And painful movements, they can be there if there is associated trauma to the muscles or in the orbit area or the eye is inflamed. So I will not be marking the right answer for this question because I find it little incomplete. The answer can be pupil sphincter tear if there is more description in the case scenario, because optic neuritis will not have non-reactive pupil, there will be Marcus gun pupil in that. So I will leave this question open till we get more confirmation about this question. Okay, so this was the square discussion about this particular. Coming to the last question of the session, recall session. A mother brings her child to IOPD with complaints of difficulty in watching blackboard. What could be the most probable reason? The choices given were myopia, hypermetropia, amblyopia, and isometropia. So here again, a good question, and the clue was difficulty in watching the blackboard, because that is the specific problem which is like suffered by the child. He may be able to read well. So the more problem is when he is watching the blackboard, that is the distant vision. Okay. So going by this, anisometropia, as we just discussed, that is difference in the refractive error, but that difference can cause problem not only in watching blackboard but otherwise also. So there is nothing specific to suggest that it is anisometropia. Amblyopia, lazy eye, but the other eye has to be good. One eye will be lazy, other eye is good. Or even if both the eyes are having suppressed vision, it will not be only for watching blackboard, then it will be for all the purposes. That is for distance as well as near vision. Then hypermetropia we can rule out, because in hypermetropia, again, the vision is defective for near as well as for the distance. But when the vision is specifically defective only for the distance, that is something like watching the blackboard, then the right answer becomes your myopia. Right answer becomes your myopia. Such children, they also tend to squeeze their eyes. Such children, they also tend to squeeze their eyes. So there can be in the history squeezing of eyes. This is to get pinhole effect. They squeeze the eye so that small amount of rays only they pass through, which could help them in clearing up their vision a bit. So when there is complaint of squeezing of eyes or difficulty in watching blackboard, then suspect myopia or the nearsightedness, because the child has difficulty in distant vision. So here the most appropriate answer will be your myopia. Right? So this session, as you saw, there were like in this exam, there were a lot of clinical case-based scenario questions, lot of questions which checked our clarity of the concepts, that when you're studying a subject, you're not only studying a subject just to kind of know the theory, but I feel that this exam was more application of the theory, that if we are reading about refractive errors, how we are applying it. They are asking you about the diagnosis, they're asking you about the management, they're asking about the anisometropia, amblyopia, similarly the ulcer based question, similarly the question based upon the contact lens use, the artery occlusion. So the application of the knowledge, as we do when we do the clinical practice, was the trend in the ophthalmology questions which were asked. So this is important to know, that have a good concept. If we have a good concept, then you can apply that knowledge to solve the question in any form when it appears in the exam. And of course, the importance of the images cannot be underestimated. There were about 4 questions average which had the images, image of the instrument, image of the leukocoria, image of the fungal ulcer. So all these are important. So always, as far as ophthalmology is concerned, always go through the important images for your exam. So that will be my message to all of you. So that brings me to end of this recall session. So I would suggest that do put your comments in the comment section if you find any additional information which will help us in refining the questions more, and which will help all of us, our colleagues, our fellow students who are going to appear in the upcoming exams. So all the best, dear friends, all the best for all those friends who appeared in FMG December 2021 for your result. Very soon, I'm sure we are going to get the good news from you people. And all the very best to the people who are going to appear for the NEET PG. I, Dr. Anuradha Dhawan, I'm available on the Gmail, I'm available on the Telegram, as well as on the missed Telegram for further any queries or discussions if you want to have. So thank you so much and wish you all the best always.